السلام عليكم ورحمة الله، أسعد الله مساءكم. اليوم تألق جديد من الإدارة العامة للأشعة والخدمات التطبيقية مع محاضر متألق الدكتور محمد القحطاني، أستاذ مساعد بجامعة الملك خالد بأبها، قسم الأشعة والتصوير الطبي، باحث سائر بجامعة ليستر ببريطانيا، مهتم وفي تطوير تقنيات الطب النووي الحديث. دكتور محمد، الله يحييك، شكرا لوجودك معنا. نتمنى يكون الفائدة للجميع، والله يحييك. دكتور محمد.
السلام عليكم.
وعليكم السلام، حياك الله دكتور محمد.
مساكم الله بالخير جميعا. الحمد لله رب العالمين، والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما وعملا يا رب العالمين. أتوقع الصوت مسموع.
الصوت واضح جدا، الله يعطيك العافية والله يحييك.
جميل. First of all, allow me to deliver this presentation in English, as there are some of my friends in the universities, they are just speaking English, and I would like them to be joining this meeting or this lecture to have fun with us for these 2 hours. One more aspect that I need to mention before I started my lecture, the logo for the University of Leicester and King Khalid University will be on my presentation, as the majority of the research work provided in this presentation has been done at the University of Leicester, and I have been fully funded by King Khalid University to do that research. So some of my friends, they have got no background about the nuclear medicine or what I'm going to talk about today. So I have kind of a brief here, what we mean by nuclear medicine. So in general, we do inject patients with radioactive material. So these radioactive materials are traveling through the bloodstream in the majority of cases. Some of them we do inject it locally, and we can trace it using a radiation detector. There are a huge technology and a huge advancement behind this branch of science, but what we are mainly doing is evaluating the function for the tissue that we are targeting. So my lecture today will be about the nuclear medicine advances in cancer diagnosis and management. So it is well known that nuclear medicine technologies and techniques are playing a prime role in the diagnosis and management for a wide spectrum of cancers. So with the current developments toward molecular imaging and the recognizable advancement for nuclear medicine equipment that used for nuclear imaging, particularly after the combining of nuclear medicine instruments with morphologic radiation instruments like CT or MRI. So that's really making nuclear medicine an integral part for cancer diagnosis and management protocols. So what we are doing in nuclear medicine clinics for cancer patients. So we do help our patients in the process of detecting malignant tumor. So we do help in the staging and restaging of the disease. Nuclear medicine is massively contribute to the process of early detection of the recurrence of tumors. So, and we are quite helpful in evaluating the response to therapy. That's including chemo, or surgical, or radiotherapy as well. So even nuclear medicine, it's very, very, very good in prediction of the prognosis for cancers. However, in this lecture, I gonna hopefully focus on the sentinel lymph nodes localization and identifications and the advanced technology behind it. So that's the major clinical uses for nuclear medicine in cancer diagnosis and management. So I will briefly discuss the diagnosis of the tumors, the pre-treatment staging of malignant disease, the detection of residual or recurrent disease, and evaluating response to therapy. And also, I will briefly talk about the radiotherapy planning. However, the core of this lecture will be focused on the sentinel lymph node localization advanced technology. So, as you can see in this image, it is for what they call it scintigraphy, and we can see the right and left breasts, which is a negative study for that patient. Such a technology, we use it as an advanced technology if we have got a mammography that's not conclusive. So here is another example. Come on. So that's another example, and we can see the focal accumulation of the radioactive material in the right breast. So that's proof there's an abnormal growth for the cancer tissue. So furthermore, there is a recent technology that I have seen in many cancer treating centers that they're using to evaluate the breast cancer, which is they call the positron emission mammography. So it's based on the positron annihilation process. And this technology is also used an advanced technique to detect the abnormal growth of tissues in the breast when the healthcare practitioners think the results of mammography is false negative or even false positive, merely for dense breasts. So here is the use for the PET-CT technology for managing different types of cancer. So for the image that you are seeing, that's solitary lung nodule with the high FDG activity as the row indicating a malignance or a malignant site. So here is another example. So we can see the primary tumor in the right breast, and we can see the focal uptake surrounding the sternum for the involvement of the lymph nodes. So we also using different technologies and techniques of nuclear medicine in staging of malignant disease. So the size of the primary neoplasm is very important parameter to stage cancer patients. So the extension through system is a valuable information that we need to evaluate the presence or the absence of the metastasis. So accurate staging of malignant lesions at the time of initial presentation is very, very critical issue, which will help us to provide the appropriate management for a particular patient. So when we compare the nuclear medicine technologies to other medical imaging technologies, including CT and MRI, we can see the using of fluorine 18 mixed with the FDG is providing accuracy reaching 90%. So when we compare it to CT, which is about 70%, or MRI, which is about 80%. So we also can use the advanced technology for nuclear medicine in detection of residual and recurrent disease. So if you look through the image, so you can see the baseline image in your left-hand side, and we can see the recurrent tumor, and with the multiple lymph nodes and spleen that's growing again for a Hodgkin's lymphoma patient. So also we can use the technology in evaluating response to therapy. So you can see this gallium-67 image. So that's for non-Hodgkin's lymphoma patient. And with the follow-up, we can see the clearance of the radioactive material and the normal appearance for the patient's body. So the nuclear medicine technologies as well, we can use it for radiotherapy planning or improving the output, the outcome of the radiotherapy planning. So fused images for FDG PET and CT providing valuable information resulting in more accurate determination of normal tissues when we're trying to see against the tumor-bearing areas. So comparing the outcome of the fused images for FDG PET and CT to the CT alone, we do improve the therapeutic window of radiation therapy. So that's kind of a brief about the majority of branches that we are helping for managing and diagnosing cancer patients. But the focus of this lecture will be in the sentinel lymph node localization and detection. So when we're trying to explain what is the sentinel lymph node, we will find a wide spectrum of definitions in the literature. But from a nuclear medicine point of view, the sentinel lymph node, it is the first node that's received the drain from the primary tumor. So when we detect it, we're trying to mark it, and we give the surgeon the ability to evaluate it and remove it if there is a need to do such a thing. So what we are doing, we do inject technetium-99m in the majority of the cases, and we do follow it using the large field of view gamma camera or SPECT CT machine. However, there is a quite big challenge nowadays. So when we have the patient evaluated and we do detect the involvement for the lymph nodes in the spreading for the tumor, for the primary site of tumor, we need to evaluate the site. We need to know the depth for that lymph nodes before we send the patient to the operating theater. It's easy to do that before we send the patient to the theater, but the problem, we end up with just a simple mark on the skin, and we say we expect the lymph node to be in this site. So what we just leave the surgeon with the patient blindly. So the existing technology that we have got inside the operating theater, that's what we call a non-imaging gamma probe. So these non-imaging gamma probe, it's providing kind of a bleeding. So when we get close to the sentinel lymph nodes, it's a bleeding or giving us a number of counts. But the learning curve for using such a device is quite steep. So the surgeon will need at least 3 to 4 years to handle such a device properly. One of the studies that I have read and published in Canada, I believe in 2009, they're trying to do a phantom study for them for the cancer surgeons, and they put a small Eppendorfer tubes inside the breast phantom, the 3D breast phantom. Then they give the surgeon a chance to check where is the sentinel lymph nodes. The highest percentage they reach is 87%. That means we send about 23% of the patients that we are treating back home with cancer. So we need to improve such technology to help surgeons to determine where is the exact site of the sentinel lymph node and help them to be confident when they're removing the sentinel lymph nodes and screening the area before and after doing the surgery. So that's the existing technique right now. So they do inject technetium-99m. I believe in the majority of the protocols right now, they don't inject blue dye anymore because the filtration for such a material, it's quite low. Then we do what they call it the preoperative imaging. So we do scan the patient in the nuclear medicine clinic. So we determine where is the primary site of a tumor and where is the sentinel lymph node. So we can even estimate the depth for the sentinel lymph node. Then after that, we mark it on the skin. We send the patient to the operating theater, and we have what they call an open AC tactic. So we just leave the surgeon with non-imaging gamma probe, and he's trying to find where is the sentinel lymph nodes. And obviously, or basically, it's working like a metal detector. So that's the non-imaging gamma probe. So it's not providing an image. That's kind of a schematic for the device. It's just providing a number of counts. And the majority of it right now, it's a photomultiplier tube-based technology. There is a big advancement in having a wireless non-imaging gamma probe or with different collimator that can provide a wide field of view or narrow field of view to avoid the problem of them scattering coming from the background. But all of these is based on the technique for the surgeon and how he getting well with such a technology. So as you can see, this is the non-imaging gamma probe. So it's a photomultiplier based technology. Some of them now they're using the semiconductor or what they call it CCD based technology, but it's not really providing an image. It's just providing number or bleeping sounds. And these the images so we can see the injection site and a potential sentinel lymph node. So what they're trying right now is to build up or develop a technology that can provide an image in the operating theater. So they can scan the patient during the surgery, determine where is the primary site of a tumor, and trace the radioactive material, the drain of the radioactive material from the primary site toward the lymph nodes surrounding the primary site. There are around 11 groups all around the world, research groups all around the world working on such a technology. Some of these technologies are already released in the market. Some of them haven't really reached the stage to be released in the market. Some of them in the CE marking. So, but one of them famous intraoperative gamma imaging system available nowadays is the Spanish technology, they call it Centinela. So it can look through the energies between 50 and 200 kilo electron volt, and it's developed mainly to detect the sentinel lymph nodes in intraoperative settings. So there are different technologies like the Crystal Cam. I believe it's a German technology. Another example of the technology like Easy Scope, which is a Japanese technology, and they can look through the energies between 71 and 364 kilo electron volts. And when they start examining on the patients, they used it for intraoperative hypothyroidism, gamma imaging. So I will show you some of the images they produced through I believe 1 or 2 of these devices. Then I will give you kind of an explanation of my experience with them, a newly developed system. So if you see in your left-hand side, this is the easy scope intraoperative handheld gamma camera. And in your right-hand side, this is the Centinela, Spanish technology. So this image is the three top images is provided by the easy scope intraoperative gamma camera, and we can see in the lower image, that is the image provided by the conventional gamma camera, and we can see the cobalt 57. We used it as a background to have a good contrast for the primary site of a tumor and the potential sentinel lymph nodes. So the camera is quite potential, so it can provide a good image for the primary site of a tumor. We can image the lymphatic vessel, and we can localize the sentinel lymph nodes within a minute. So that's a quite good technology available, but it's just providing gamma imaging only. So through my experience with the bioimaging research group at the University of Leicester, we managed to develop a handheld multimodality gamma imaging system. So that's what we call a hybrid gamma camera. So it is a CCD-based technology, and we do attach directly a scintillator or a scintillation material, or what we call a cesium iodide dubbed with thallium. And you can see the structure for this crystal. So it's what they call a columnar crystals. So it's channeling the light after the interaction and improving the spatial resolution even when we use quite thick crystal. So that's a pinhole collimated camera, so to provide a quite wide field of view to allow the surgeon to screen a wide region, and it depends on the distance between them targeted tissue and the camera. So if we need to screen larger area, we need to go a bit further from the patients. If we're trying to focus the camera on a specific region, we need to get it a bit close to them tissue of interest. So that's the gamma images provide at them camera face. So that's at 25 millimeter, and we can see how the field of view is widening with the distance, and that's at 75 millimeter. Furthermore, the camera is providing optical imaging at the same time. So we can provide superimposed gamma and optical imaging at the same time. It's a quite simple idea. So we have got 45-degree mirror in front of a small optical camera that's reflecting the field of view. So it's providing similar optical and gamma field of view. So you can see the camera while I hold it. So it's a quite small, it's like the ultrasound probe. So that's kind of a simulation when we're trying to scan the thyroid gland for one of our colleagues in the research group. So what's really the benefit for such an advanced technology? It's providing a real-time imaging. So we can do a dynamic imaging at the same time while the surgeon doing his or her procedure. So we have got the optical guidance. So it's not just seeing the gamma image but you can add the anatomical information for them for the field of view using the optical guidance. So it's suitable for small organ imaging as a small field of view gamma imaging technology. It's easy to handle. It can be a handheld device. It can provide a relatively large field of view as we used a pinhole collimator, which is based on the distance between the targeted tissues or where is the activity accumulated and the collimator surface. And it's to provide superior spatial resolution because we are using cesium iodide doped with thallium scintillator, and it's a structure as a columnar scintillator, which is channeling the light through it to improve the spatial resolution and preserve the sensitivity. So let me give you kind of a sense about the spatial resolution that's provided by such a system. So you can see in the graph in your left-hand side the full width at half maximum and full width at 10th maximum. That's kind of how we characterize the spatial resolution, even when we're looking through it in intrinsic or extrinsic settings. So that's what we call a small well phantom. So we have got a tiny wells that we filled with radioactive material. Can see the second image that's provided by a conventional large field of view gamma camera. They call it Medisu gamma camera, which is a Hungarian technology. And that's the image provided by our camera, the hybrid gamma camera. So it's provided very distinct images. We can see the edges for the well, even the distance between the central of the small well and the large well is 15 millimeter. So we can see the small sentinel lymph nodes and we can differentiate it from the surrounding tissues. So that's why we have a high or superior spatial resolution. That's because, as I mentioned, we use a columnar scintillator. So you can see the interaction for the gamma photons inside it. It's reflecting in each needle. So each needle or each tiny column, it's working as a separate or independent crystal. So that's providing a high absorption when we get a thick scintillator. At the same time, it's to preserve a high spatial resolution because each column, it's interact as a separate crystal. So in the normal or in the conventional gamma camera, we do have the crystal with different thicknesses, but all the time it's kind of a trade-off. So when we increase the thickness, we improve the sensitivity, but at the same time, we lose the spatial resolution. So after the development for such a technologies, we starting doing the phantom studies. Then after that, we do the preclinical studies. Then we end up with the clinical studies. So we will go through it briefly, hopefully, in this lecture. So that's kind of a phantoms that we're prototyping in the University of Leicester. So that's a small perspex phantom with different simulated sentinel lymph nodes having different concentration of radioactive material and different diameters. So we can evaluate the simulated sentinel lymph nodes at any simulated depth, any simulated size, any simulated concentration of radioactive material. So that's given us kind of a comprehensive overview of the sensitivity from a practical point of view. So the table below, I do provide them the activity that we're using, which is ranging between 0.025 megabecquerel to 4 megabecquerel. So I will show you the outcome. So we do use different scintillator thicknesses. So we do use them 600 micron thickness cesium iodide doped with thallium scintillator. and we do use 1.5 millimeter thick cesium iodide dipped with thallium scintillator. When we increase the thickness all the time, that's mean we're increasing the sensitivity. But in this scenario, we do increase the sensitivity, but we do preserve the spatial resolution, as I mentioned, because we have a columnar scintillator. And also we do use different pinhole collimators with different sizes. So we use one with 0.5 millimeter diameter and the other one with 1 millimeter diameter. So while we use the 1 millimeter diameter pinhole collimator and the camera is fitted with 1.5 millimeter thick cesium iodide dipped with thallium scintillator, and during 60-second acquisition time, we are capable of detecting 93.75% of the simulated sentinel lymph nodes, which is a quite good outcome in this short acquisition time. So that's the image provided. So that is under the 25 millimeter of scattering material, and you can see here the well A, it contained 50 kilobecquerel of the technetium-99M, and the well B, or the simulated sentinel lymph node B, it contains 25 kilobecquerel, which is a very, very, very low amount of radioactive material, and we are capable of detecting it in 60 seconds. So then we're trying to do using anthropomorphic head and neck phantoms. We do 3D print a thyroid phantom with the normal size for an adult. And we do simulate the right and left lobe for the thyroid gland and thymus as well. And we do hold it on an internal jig that we insert it inside the head and neck phantom. Then we put a small Eppendorfer tube with the volume of 0.2 milliliter, and we filled it with different concentration to simulate the sentinel lymph nodes in quite realistic scenario. So then we compared it with the existing technology. So we do compare the outcome of the hybrid gamma camera, the newly developed technology, with the existing technology, which is the SPECT CT. And you can see the differences between the images provided by them SPECT CT and the images provided by the hybrid gamma camera. So we can detect the simulated sentinel lymph nodes in all scenarios, even when we start with 10-second acquisition time. So that's a quite promising to go further with such a technology. So when we do calculate the contrast to noise ratio for these simulated sentinel lymph nodes, the majority of these nodes are in the region of detectable lymph nodes. So we can see all of them with all scenarios, with all concentrations that we are using. Then we do a kind of an experiment to evaluate the ability of that system to image small organs like thyroid gland, the inguinal region, or looking to the injection site while we're doing the lymphoscintigraphic procedures. But here we're trying to see how well is the camera to provide the details for the thyroid in experimental setting. So we do use two different collimators, which is 0.5 millimeter diameter pinhole collimator and 1 millimeter diameter pinhole collimator. We have used different acquisition time ranging between 100 seconds and 400 seconds. And you can see the count profile for them both lobes, the right and left lobe. And we can distinguish these lobes with a good spatial resolution. So when we fit it with the Gaussian fitting, we can see a good value of full width at half maximum. These two images showing the merits of having an optical imaging or a real-time optical imaging while we acquisition the gamma images. So in your left-hand side, you can see the thyroid gland, the superimposed optical and gamma image at 100 millimeter from the surface of the collimator. And when we're looking to the image in your right-hand side, we can see the thyroid at 200 millimeter away. And we can see, even if we change the distance, we are not really losing the spatial for the image. So we can see the superimposing for the gamma and optical images in the right positioning. So that's kind of a short clip showing you how we can provide a dynamic image. So imagine if we use such a technology in the theater, we can scan the lymph nodes and provide a detailed image in real time. So that's the thyroid gland. So it's not a static image, it is a dynamic imaging. So we have a quite promising outcome for such a technology in the experimental settings. So we need to take it a bit further to do some preclinical studies. So we do 3D print small animals to evaluate the system and do some advanced protocols with it. So we're trying to do kind of a SPECT imaging for the lungs of the mouse, of the 3D printed mouse. Then we trying to examine our system against the available technology. So we do acquire this image in Leiden University at Netherlands. So, and you can see here the existing technology of USPECT. Acquisition time for the image in the right hand side is about 33 minutes. And they use them slice thickness is for a whole field of view. But in the left hand side, you can see the image provided by them, by our advanced technology, with the acquisition time of 5 minutes, which is quite short acquisition time. And you can see the merit of having the optical while we have got the gamma image at the same time. So we need to take it a bit further to see how is it behaving with the clinical studies. So we're trying to use it for the routine techniques that we are handling in nuclear medicine department. So we're trying to use to examine such a technology against the thyroid scintigraphic procedures. So that's kind of an image for a patient. You can see the image in the middle here, which is the gamma image, the optical, and we can see the hybrid. So we do image this patient after 1 hour and 50 minutes post injection of the radioactive material, and the acquisition time was about 5 minutes. So it's not really that long acquisition time with the detail that's provided. So when we're trying to examine the technology against the existing technology, in your left-hand side, you can see the image provided by the large field of view gamma camera, and we can see the focal uptake in the right loop in the conventional image. We providing similar outcome using the newly developed technology. So then we're trying to see if there is a merit to use such a technology for lacrimal scintigraphy, so we can trace the patency for the lacrimal system and compare it to the existing technology or to the gold standard that we're using to evaluate the obstruction in the lacrimal system. So the images here, which is provided by the large field of view gamma camera, and we can see the drainage, the obstruction in the left eye, and the drainage in the right, the normal drainage in the right eye. So similar information has been provided by them hybrid or the small field of view hybrid gamma camera. So then we test it for them lymphoscintigraphic procedures. So you can see the merits of having the hybrid imaging. So that's the injection site. And when we compare it with the large field of view, you can see the focal uptake in the left side, in the inguinal region, or in the left inguinal region, and a very detailed image has been provided by the hybrid gamma camera for the region of interest when we compare it with the large field of view gamma camera. So that's to provide a superior spatial resolution. We can resolve the focal uptake in the inguinal region. After that, we started a clinical trial to evaluate the usefulness of such a technology with them while we doing a sentinel lymph node biopsy procedures. But we didn't manage to get the system to the theater because it's still in the process of CE marking. But we managed to evaluate the patients before we send them to the theater. So for that patient, they do inject the patient in the leg, so we can see the injection site. And while we're using the hybrid gamma camera, we can trace the drainage of the radioactive material from the injection site toward the potential lymph node. So you can see here the Nike logo on the trouser for the patient, and we can easily localize the potential sentinel lymph node. So that's at 16 centimeter imaging distance. And when we get closer to the patient, we can get quite distinct image. So imagine if we take such a system inside the theater, so the surgeon can determine exactly where is the sentinel lymph node before he or she started the surgical procedure. So here is the images for the same patient at different imaging distance, which is 4 centimeter, and we can compare it with the existing technology that we used, which is the SPECT CT. So what is next with such a technology? So we're trying to build up what they call a multimodality system. So with the improvement now of the dual tracer, they're trying now to mix the radioactive material with the fluorescent traces. So imagine if we have a system that can provide fluorescence imaging, gamma imaging, and optical imaging at the same time. So that's kind of an example of what we're trying to do. So the main drawback for the near infrared fluorescent imaging, it couldn't really go further inside the tissues. But while we have got the gamma imaging facilities, we can localize the deep sentinel lymph nodes. Then while the surgeon doing the surgery, he will get close and close to them. He'll get closer and closer to the potential sentinel lymph nodes. And the fluorescent tracer will give us a very, very distinct markers for the margin of the potential sentinel lymph node. So that's kind of an imaging for the dual tracer inside an Eppendorf tube. So we can see that's provided by our system. So we can see the fluorescence, the gamma, and the hybrid, the fluorescence, optical, and the gamma at the same time. So then we try to do kind of a fluorescence imaging just using our system, and we do provide quite good images. So to summarize the whole story, the project go through 3 stages. So it started with the development for the technology, then which is involvement of them, selection of them, of what kind are we gonna use them, photomultiplier tube, or we gonna use the semiconductor, what kind of CCD that we're gonna use. Then we go for the selection of the scintillation material, how is it gonna be built, then we examine it, we do select them, the kind of collimator that we're going to use. The stage 2, we start doing the assessment. That's including the experimental work, designing the phantoms, doing the preclinical studies, and end up with them with the clinical trials. At the moment, the project reaching the stage 3, which is now in the commercializing process and in the CE marking process. Hopefully within the 2 years, going to be dashed in the market. So final story for nuclear, final message for the nuclear medicine lover. I believe nuclear medicine has got lots of surprises that are coming in the near future, mainly in the technology stream. So thank you so much for your listening and for your time.
يعطيك العافية. شكرا لك دكتور محمد. إذا في أحد عنده سؤال. Any question for all? في سؤال هنا دكتور محمد يقول how can differentiate between malignant nodules and from inflammatory one.
ما سمعت السؤال.
طيب how can differentiate between malignant nodule from inflammatory one?
We need to look through the history for the patients. So when we're trying to do the nuclear medicine imaging, we are not just providing imaging without reading the history for the patients. So nuclear medicine technology is almost advanced technology. So the patients need to go through the CT, the conventional X-ray first, and we need to read the symptoms for the patients, why he's coming to the nuclear medicine department. So I know the inflammation is providing an abnormal uptake or a high uptake, focal uptake for the radioactive material. It's quite difficult to differentiate between them while we're looking to the image unless we know the history for the patients.
Good.
عادي إذا في أي أسئلة بالعربي okay.
طيب.
I just mainly doing the.
دكتور عبد العزيز مسبعي في question.
السلام عليكم. يعطيك العافية دكتور. كيف
الله
حالك؟
الله يعافيك يا دكتور. حياك الله.
الله يحفظك. تشرفنا بك وتشرفنا بهذا المجهود. My question, was there any trial locally in for this involvement or all the cases and outside?
والله يا دكتور عبد العزيز, I'm trying my best. If you have got a path for me to do something locally, I'm more than happy, and I believe the research group in Leicester, they are more than happy to get them the system here in Saudi Arabia to do some clinical trial. The big issue
is it ethical part or
it is not really ethical part. It's about the process. You know, when we're doing the last clinical trial in the UK, it takes almost 2 years to do the paperwork. So it's quite tedious job. But I believe here in Saudi Arabia, it's way easier. So if there is a surgeon interest, if there is like a surgeon who really interested in using such a new technology, why not? And it's quite a hot area of research.
Excellent. I'll try to arrange with Basim if we could help on this part as part of the radiology administration at MOH. Hopefully we could help in this regard.
Please, if you can. جزاك الله خير.
شكرا دكتور عبد العزيز. باذن الله ان شاء الله يكون بيننا تواصل على الموضوع هذا. في اخوي تركي عنده سؤال كذلك.
ايوه السلام عليكم.
تفضل اخوي تركي.
عليكم
السلام.
بس ممكن دكتور ترجع للسلايد حق السنترال انجكشن لو سمحت، معلش يا دكتور، اللي في البدايات السنترال انجكشن، السنترال حق البريست كانسر.
ابشر. والله ما ادري وش تقصد فيها، لكن نرجع لين تقول وقف.
اي بس السلايد حق أو في البدايات أو في المرة في البدايات.
طيب. هذا صبر شوي بس. هذا
لا لسه باك
هذا
ايوه بس هنا. ايوه لا اللي قبلها هذا.
طيب بس خليه يرجع شوي، خليه اعطى شوي صبر. هذا
ايه مزبوط. دحين هنا في الايميجينج هنا الانجكشن كانت هنا in one side ولا كانت كيف كانت الانجكشن وقتها وقت الترايل هذه؟
طبعا الصور هذه ما هي من الترايل احنا سويناها، انا بس حطيتها علشان يعني to explain the concept. طبعا اذا كانت 4 injection 5 injection 1 injection I don't know، ممكن هذه الصورة اخذوها مثلا بعد ما حقنوا المريض ولها مثلا ربع ساعة نصف ساعة، يعني ما I couldn't really differentiate، عرفت؟ لكن هذه تمثل injection site وهذه هذه potential sentinel.
Yeah, talking about the injection site, usually we give 1 injection ولا usually in 4 injection like 12 o'clock, 6 o'clock, 3 o'clock and 9 o'clock?
والله it depends on the procedure they are following in a specific center. بس اللي شفته أنا في بريطانيا إنهم يستخدمون 3 4، بعضهم يستخدم 2، ما شفت أحد يستخدم 1.
اوكي.
طبعا هم يقسمون الجرعة، يعني إذا كان مثلا تحقن المريض ب 20 ميجا بكرل تقسمها مثلا على 4 سرنجز وتحقنها يعني تحقنها في 1 region بس 4 injections زي ما ذكرت with clockwise.
Yes. بس هذا كانت البوينت اوف انترست، عشان بصراحه انه I never seen one injection يعني in one of my centers before يعني.
لا هذه ما هي، ترى هذه ما هي 1 injection، هذه ممكن الصورة أخذت يعني بعد فترة.
ممكن ايه.
لو تشوف الدرينج اوريدي وصل للسنتينل ليمف نود.
Yes مظبوط.
ممكنها ميكست اوريدي.
Okay, thank you so much.
You're welcome.
We have a question here. Does this work in on detection pulmonary embolism in lungs and heart attack, or only special for cancers?
From the interest for the project, it's for small organ imaging. Small organs, I mean like thyroid, lacrimal drainage procedure, and the sentinel lymph node detection in intraoperative settings.
Good. Any more question? We have another question here. Can we try it on the kidney?
On the kidneys?
Yes.
We have tried it with one patient and we really didn't get quite successful images. So it's worth a trying, but it's really out of the scope for such a technology. I don't know, maybe in the future, why not? But you know, there is like a bit of calculation when we are trying to get them the care for them excretion of the radioactive material from the kidneys. Such a technology, it's not really providing these details.
Good. So the question they ask about the precautions and the radiation safety during the procedures. Is it safe?
طبعا, I believe the majority of you knows the gamma camera, it's not producing radiation. So it's detecting radiation from the patient. So based on what we are injecting and how we deal with it. So the technology has nothing to do with radiation protection issues. So it's merely detecting the radioactive material that's coming out from the patients. So I couldn't really see any radiation protection issues here.
Good. So thank you so much. الله يعطيك العافية، يبارك في عمرك. شكرا لك، شكرا لوقتك. بارك الله في جهودك. إن شاء الله ما تكون الأخيرة بإذن الله. نيكون عندنا لا زال هو في الوزارة، هو قائم وله مستقبل قوي جدا، وهو يعتبر لا زال بكر في كثير من الأماكن. إن شاء الله حيكون بيننا تعاون أكثر ومحاضرات أكثر. شكرا لك وشكرا للحضور.
يعطيكم العافية، ما قصرتوا. يعطيكم العافية.
شكرا لكم. بالنسبة اللي سألوا عن الشهادات، نفس الشروط السابقة، حضور 75% من الدورة، وترسل ان شاء الله اوتوميتد لكل الحسابات او الايميلات المسجله، الاسم كما هو مسجل. المحاضره مسجله في اليوتيوب، هي لايف الان وحتكون مسجله هناك. يعطيكم العافيه، شكرا لكم جميعا.